welcome you all to our first community seminar of 2021 from the comfort of your home or from wherever you may be joining us. Before we begin, I would like to acknowledge the traditional custodians of the land on which I stand, the Awabakal and Warramai nations, and pay my sincere respects to elders past, present, and emerging, both here and from wherever you are watching. Thank you for joining us. We've got over 370 people registered for the Zoom session tonight, so welcome. So 2020 was a year like no other. The challenges we faced emphasised the importance of taking care of our own health and being mindful of the health of others. Tonight's virtual seminar, our first for the year, Heart Health, a heart-to-heart with HMRI, will focus on what we understand from research into heart attacks, what cancer has to do with your heart, and why exercise is important to maintain good heart health. To give you some insight, cardiovascular disease is the leading cause of death in Australia, accounting for 30% of all deaths, and an estimated 22% of Australians experience cardiovascular disease at some point in their life. The cardiovascular program at HMRI researches causes, treatment, and management of cardiovascular disease and cardiovascular health amongst Australians of all ages to improve the health outcomes of the single largest cause of disease burden in our country. We're very lucky here at HMRI to have the cardiovascular group here in Newcastle, and it's uniquely positioned to improve the health outcomes of the community by combining laboratory researchers with clinical cardiologists and nutritionists and physical activity researchers. We're allowed time for questions at the end of the talks, so please send them through via the chat function on the Zoom. Throughout the event, we'll collate them and endeavour to answer as many of those as possible. So to start with, I'm delighted to introduce Professor Andrew Boyle, our first speaker tonight. Professor Andrew Boyle is a clinically trained cardiologist and respected leader in cardiovascular research. He has a keen interest in the reparative processes in the heart after heart damage and how to reverse scarring and tissue damage after heart attacks. He is interested in cardiovascular health, which is lucky for a cardiologist to be interested in that, in particular why people are suffering heart attacks at such a young age. He leads a successful research laboratory based here at HMRI, where he studies preclinical models of the ventricular remodeling and is also an active clinician and clinician researcher at the John Hunter Hospital, working to improve the outcomes for people impacted by heart attacks and damage to the heart muscle. Andrew's presentation will focus on innovations in heart attack care in the Hunter region. Welcome, Andrew.
Thank you, Giovanna, and welcome to everyone watching from home. It's a new format for me, these Zoom presentations, so hopefully we get through this smoothly. So in the Hunter region, we suffer from among the worst heart health in the nation, which has been the way for a long time and is not improving. And so we've been pushing forward in research in a number of different fronts to try and improve outcomes for patients who suffer heart attacks in our region. Cardiovascular disease is the #1 killer of Australians. More than any other disease group, more than cancer, more than trauma. Cardiovascular disease includes heart attacks, but also includes other disorders such as stroke, heart failure, aneurysms, and other vascular diseases. And when you sift through those cardiovascular diseases, the #1 single disease killer of Australians is heart attacks. Data released by the Australian Institute for Health and Welfare shows this. This graph shows both for males and females, coronary heart disease is among the top killers. And if you add those together, that's more than dementia, stroke, lung cancer, and chronic obstructive lung disease. And this slide, while a little busy, is really important. A lot of people consider heart disease to be a disease of the elderly, but it's not. if you look at the age groups down the left side of this and the first, second, third, fourth and fifth leading causes of death in those age groups, by the age of 25 to 44, coronary heart disease becomes the fourth leading killer. And thereafter, from the age of 45 onwards for the rest of your life, it's either the first or second killer of Australians. If you ask most 25 to 44-year-olds, they won't think they're at risk of heart disease, but they are. Acute myocardial infarction is the medical term for a heart attack. It's caused by a buildup of cholesterol plaque within the coronary arteries. This picture shows the coronary arteries, which are these blood vessels on the surface of the heart. And with each heartbeat, about 10% of the circulation comes back through the coronary arteries to feed that heart muscle and keep it pumping. Over time, cholesterol can build up in these arteries, slowly strangling them and cutting off the blood supply to the heart muscle. This is stable coronary artery disease. It takes many years to build up and can lead to the need for procedures like bypass surgery or coronary stents. But occasionally that becomes acute. And in this figure, you'll see a blood clot has formed on that cholesterol plaque, and those blood clots form in seconds. They usually lead to a sudden onset of difficulty breathing and tightness in the chest, and they block the artery completely. Once there's no blood flow, the muscle downstream is starved of blood flow and begins to die. And those muscle cells die within minutes, and that cell death is irreversible. One of the complications of a heart attack, some people can survive this just with a bit of heart muscle damage, but a proportion of people will have an irregular heart rhythm due to this blockage and will die suddenly. That's unpredictable. We can't tell who that's going to happen to or who will survive. So it's important that when these symptoms come on, we treat everybody and we treat everybody quickly. So what are the warning signs of a heart attack? How do you know if this is happening? Well, the warning signs, unfortunately, are variable. They're variable from person to person. But you may experience things like pain, pressure, heaviness, or tightness in the chest. It may radiate up to the shoulders or up to the throat or the neck. It may go down the arms or up further into the jaw. Some people feel it in the back. The associated symptoms that you may also feel include nausea, dizziness, sweatiness, clamminess, and shortness of breath. But those symptoms can be variable. Some people may just have the jaw pain, or some people may just have the shortness of breath. So it's important to be aware of these symptoms, and if you have a level of suspicion that something's not right, to get them checked out and get them checked quickly. These graphs show the rates of heart attacks in the Hunter, New England region over a 20-year period. The top graph is males and females, the bottom graph is by age. It doesn't really matter the detail, but you can see it's a straight line. Most of the developed world is seeing a decline in the rate of heart attacks due to better health, better nutrition, smoking cessation, various other public health campaigns. We're not seeing that here. We're not seeing the gains that most places are seeing. I want to tell you just a story about my own father and how illustrative this is of the change in therapies over the last 50 years. My father had a heart attack in 1970, and he was living in Melbourne and was admitted to the Alfred Hospital, which is one of the premier cardiac centres in the country. It's the only heart transplant centre in Victoria, a very prestigious institution. And he was treated with 2 weeks of bed rest, and that was it. There was no coronary care unit, there was no ECG monitoring patients. Had he suffered one of those arrhythmias and died suddenly, no one would have known. And he was still smoking in his hospital bed and didn't even get an aspirin. But that was state-of-the-art care in 1970. And that's not that long ago. I think most people watching from home will have been around in 1970. So the current treatment is, the first diagnostic tool is an ECG, an electrocardiogram, which is cheap and efficient and helps diagnose and risk stratify patients very quickly. Cardiac enzyme tests have become much more sensitive and much more specific to give an accurate diagnosis. And in fact, those things can be done on a finger prick blood test at the bedside without having to send it off to pathology, can be done in small rural hospitals at 2 o'clock in the morning and give you a result within minutes. Probably the most important innovation has been restoration of coronary blood flow, and that means to open the blockage in the coronary artery and to do it as quickly as possible. I'll talk a bit more about that in a moment. Coronary care units came up in the late 1970s, where patients are monitored 24/7 on their ECG. The nurses out in the station can see if they have an irregular heart rhythm and their heart stops and rush in and resuscitate them. And that saved a lot of lives throughout the world. Aspirin, pretty simple, saves lives. Other medications, I won't go through all of them, but each of them has been proven in clinical trials to improve the outcomes of patients who've had heart attacks. We now know that mobilising early, not resting in bed for 2 weeks, is better for patients. Early discharge is better, associated with better long-term outcomes. And in fact, some patients are home as early as 2 days rather than 2 weeks. And once they go home, cardiac rehabilitation for education support, what diet's appropriate, what exercise regimen can be tailored to an individual, has been shown to prevent recurrent heart attacks. So in just 50 years, we're in a completely different place, a completely different landscape for heart attack care. And the mortality has reduced substantially because of all of those things. So it's only dumb luck that my father survived in 1970 and that he went on to have my little sister. So I may have not had a little sister had he not been just lucky. And why do I say restore blood flow quickly? Well, this graph really shows the importance of getting arteries open quickly. If you look along the bottom of this graph, it talks about ischemic time. That's the time from the onset of the symptoms of chest pain with a heart attack. And on the vertical axis, it shows the rate of dying from that heart attack. Now, if you get to hospital quickly and the artery gets opened within an hour, only about 3% of people will die. If that blows out to 3 or 4 hours, you double the rate of death. Out to 6 hours, you triple it. And that graph continues to rise. So time is important. If you have heart attack symptoms, call 000, please. Don't worry about it being a false alarm. That's what it's there for. If you wait till the next morning, wait to see your GP, the damage is often done and it's too late to reverse it. That's why we're on call 24/7. If you have a heart attack at 2 o'clock in the morning, people will come in from home and open that blocked artery quickly for you. But that leads us to the big problem that we have in our geography, which is that the Hunter New England Health District is massive. It's the size of England. And we are located down in this one little corner here. So there can be 600 kilometres from up in Moree if you're having a heart attack at 2 o'clock in the morning. And the transport times, if you remember the previous graph, can be out to 6 hours where you're right at the top of the mortality curve. So how do you deal with such complex and challenging geographies? Well, the answer is technology. And so when we look at the most serious type of heart attack or myocardial infarction, a STEMI, ST elevation myocardial infarction, this technology of an ECG is quite old technology, but now it's miniaturized and it can be put in every ambulance. In fact, it's now in every ambulance in the state of New South Wales. Not only can they record an ECG, but the algorithm can read it and transmit it to smartphones anywhere in the world. So whoever's on call gets the ECG sent to their smartphone with a callback number, and we can discuss it with the ambulance paramedic who's in the back of the ambulance with the patient. So in consultation with the ambulance paramedic, they tell us how far away they are. If they're within 60 minutes, they'll come into the John Hunter Hospital and come into the cardiac catheterization laboratory here. And these doctors are putting some tubes up through the patient's wrist into the coronary arteries and restoring the blood flow. And that's the most efficient and effective way to do that quickly. And that can be done if you're close by 24 hours a day. These videos aren't playing, that's just an example. But if you're not within 60 minutes of John Hunter Hospital and that heart muscle is dying, second best option is to give a clot dissolving drug. And so we worked on a protocol with Ambulance New South Wales and instituting ambulance paramedics delivering this care rather than waiting till they get to hospital for the doctors to administer the care. And what we found is that the rate of death at 1 year for PHT, which is pre-hospital thrombolysis, that's the ambulance paramedics giving the drugs before coming to hospital, versus primary PCI, which means coming to the cardiac catheterization lab and manually opening the blockage. And you'll see that the rate of death is the same at 12 months. So effectively what that means is that we've delivered as good a care to a patient in Moree as we can someone who lives next door to John Hunter Hospital. which is remarkable. And that is extended out to now over 5 years of follow-up, and those gains are consistent over time. And so we published that in the Medical Journal of Australia, and that's now supported the New South Wales State Cardiac Reperfusion Service, so that every ambulance in every regional and metropolitan area of the state has the same protocol. So what about after a heart attack? After a heart attack, you're at risk of a subsequent heart attack. But the other thing you're at risk of is developing heart failure, which is a weakening of the heart muscle. And it results in inability of the heart to keep up with your daily demands. And some people would go on to develop this after a heart attack and others don't. And we don't understand exactly why that is. But we looked at this in our population and we showed the following. In 2 different time periods between 2005 and 2008 versus more recently 2009 to 13. And we showed that if you survive a heart attack and do not develop heart failure, you do pretty well. 90% chance you'll be alive over the next few years. And that's improved a little bit over time. But if you are one of the ones who develop heart failure, 50-50 chance you'll be alive. And in fact, that seems to be getting worse in the more recent era. So why is that? We don't understand the underlying reasons for that, but we think it's a complex mix of environmental and genetic factors. There are differing responses to medications in different people. And so we've launched a multidisciplinary translational research pipeline to try and address these questions. And here at John Hunter Hospital, HMRI and University of Newcastle, we have been looking at exercise programs, which you'll hear a bit more from Narelle, aggressive smoking cessation campaigns, better equipment in the cardiac cath lab to more safely and effectively open arteries, repurposing old drugs which can help in specific patient subtypes. We've discovered, we're looking more into novel risk factors, particularly environmental exposures and genetics. In the laboratory, we look at different gene expression patterns and how to silence certain adverse genes and how to enhance genes that are effective for cardiac repair. And our nutrition and dietetics group have been awarded some major funding to look at diet interventions after heart attacks and preventing recurrent heart attacks. So attacking this from all different fronts, I think, is the only way to tackle such a complex and difficult disease. If I have time, I might talk to you about the SMURFs. So the SMURFs are not just little blue people on cartoons. They're also, it's an acronym for Standard Modifiable Risk Factors. And we think about these in medicine and cardiology as diabetes, high blood pressure, smoking, and high cholesterol. We think they're modifiable because you can alter them with drugs and behaviours. And we think that these, we've traditionally thought that these are the cause of heart attacks. But more recently, it's been recognised that the majority of heart attacks, there's an increasing proportion of heart attacks in patients who have no risk factors whatsoever. In fact, that proportion has doubled in the past 20 years. And I see that quite a lot, actually. You see young men come in with a heart attack and ask if they have a family history, and their father had a heart attack at 40 as well, but he smoked. And they always put it down to the smoking. But, you know, the same things happen to them who've never smoked, and it's potentially a genetic predisposition, but also potentially some shared lifestyle exposures that are clustering in that family. We okay for time? Okay. So we started looking at environmental exposures, and we've been looking at a number of these, but the one we just published recently was the relationship between fast food outlets in regional Hunter, New England, and the rates of heart attack. And in fact, there's a very clear and linear correlation between the number of fast food outlets in a regional town and the number of heart attacks. So simply having McDonald's near you increases your risk of heart attack. And it's interesting, there is one outlier here, that's Dungog, which doesn't have any of the top 10 fast food outlets, but still has a fairly high rate of heart attacks. So I think we need to look a bit more closely at that. But otherwise, it's a fairly linear relationship. There are others, but in the interest of time, I'm going to stop there. So thank you for attention. I look forward to answering some questions afterwards.
Thank you, Andrew. It's fascinating to learn about heart disease and the treatments over the last 50 years. So I think that's really, really interesting. Next, we're going to hear from Associate Professor Aaron Sverdlov, who is a cardiologist and a clinician scientist with a proven track record from discovery science through to clinical research. His research interests encompass a broad spectrum of topics related to heart failure and cardio-oncology, cardiovascular complications of cancer therapies. He's committed to improving management and outcomes for patients with heart failure through a better understanding of the mechanisms involved and discovering novel biomarkers and therapies. Aaron's presentation will showcase cancer and the heart. Welcome, Aaron.
Thank you very much. Thank you, Giovanna, and thank you everyone for giving up your time this evening to listen to our talks. So, as Giovanna mentioned, my talk is about cancer and the heart, and I guess we're going from Professor Boyle's presentation of something that's been around for a long time to something that's actually quite new and emerging. So the first question, of course, is, well, what does cancer have to do with your heart? They seem to be two quite different health problems. So the question is, well, they are, but what happens when those two worlds collide? And as Professor Boyle said, heart disease is the most common cause of death in our society, and cancer is very close second. So if you can imagine, having both of those problems is really big, has really big impact on your health and on those around you. And heart disease in people who have cancer can develop before their cancer, can develop during the treatment, or can occur after the cancer has been cured. And the good thing is the cancer treatment, of course, is more effective and getting more and more effective with time, but it does have a price. And the treatment choices for heart disease and cancer have significant overlap and are frequently, to a degree, in conflict with each other. So first, the good news. Cancer treatment is indeed getting more effective. Our cancer colleagues, cancer physicians are doing a fantastic job at improving health of people with cancer. So this is Australian data, as you can see. Currently, for all cancers combined, there is a 70% chance that a patient with cancer will be alive 5 years down the track. And for some of the really common cancers like breast cancer, that is up to 90%. That is really remarkable, especially if we think about what was happening 20 or 30 years ago when that number was less than half of what it is now. So that's the good news, but what does it mean long term? So the number of cancer survivors, as you can see on the far left, is increasing around the world and is about 30 million people now. But if you look, unfortunately, other than the cancer, heart disease is the next most serious problem that these people develop, and they have a 33% excess in the risk of dying within 7 years of surviving their cancer. And if they do develop, and if these people do develop heart disease related to cancer treatment, that type of heart disease has worse prognosis than the same form of heart disease that's not related to cancer. And so when we talk about heart disease related to cancer, what do we actually mean? And unfortunately, with a wide variety of different anti-cancer medications, they have varying effect on the heart, on the blood vessels, on the brain. And so it's very difficult to pinpoint what could be the complication. Some of those medications as a side effect can lead to weakness of the heart muscle. Some can induce heart attacks or chest pain related to blockages in the heart arteries. They can increase pressure in the blood vessels in the lungs, cause blood clots in the legs or the lungs, cause normal common garden variety blood pressure, but in people who otherwise shouldn't get it, and increase the risk of stroke and heart rhythm problems. It is a new area of medicine. And in fact, the first conference on cancer in the heart was only held 11 years ago. And there was quite a remarkable statement from one particular patient who got up. And she said, look, when I was diagnosed with cancer, I felt I could cope. I was told my chances are pretty good. I was very positive. But then, unfortunately, she developed heart failure due to treatment side effects, and that was too much for her to take in. She became quite depressed. Luckily, she survived both conditions and was there to tell the tale. But that's in summary what can happen. So what is actually cardio-oncology? It's a discipline where we focus on looking after heart and blood vessel health of people who live with or beyond cancer. And so our goals is not to say cancer treatment has the problems. Every medication has side effects. The goals are really to help people deal with those side effects, basically optimize people's heart health so that there are no delays to receiving treatment for cancer, to support any cancer treatments that can have effect on the heart, and deal with them as they come or prevent them if we can, and facilitate timely cancer treatment. We're aiming to prevent heart disease if we can in those patients through better communication between cancer doctors, heart doctors, and all the allied health professionals. The idea is to improve outcomes for people living with and beyond cancer through better adherence to cancer treatments, so that because their heart disease is not an issue, but also in developing programs of looking after the heart health in the long run. It is a team-based approach. We can't do it ourselves as heart specialists. Cancer physicians can't do it on their own. So it's a teamwork between cardiologists, cancer doctors, nurses, pharmacists, and researchers working together. So as I mentioned, some of the problem is side effect of cancer treatments, but why is there such a problem? Well, first of all, unfortunately, the risk factors for heart disease and for cancer frequently overlap. Getting older, and our population is getting older, and that's risk factor for both. Smoking, poor diet, overindulgence in food, alcohol, physical inactivity is a risk factor for both, and environmental factors, as Professor Boyle alluded to before. But also treating both conditions, we're actually at yin and yang. With cancer, what we want to do is kill cancer cells. We want to destroy the cancer as quickly as possible. So we want to stop cancer cells from being able to repair themselves. With heart trouble, it's the reverse. Once the heart cell dies, it dies. There is no regeneration. So if the side effect of cancer therapy is that heart cells die, that's a problem. And that's how most of the side effects of cancer treatment develop. With the cancer, we want to stop cancer blood vessels from growing because that's what causes cancer to spread. But with the heart, we want heart to have as many blood vessels and bypassing blood vessels around it as we can. So if the problem develops, there is collateral blood supply and so on. And here is where this balance becomes very, very important and very delicate. So what can we do about it? In reality, what we want to do is try and identify people who are at the highest risk of having heart complications related to cancer treatment. We want to identify these people early. And by doing that, then we can monitor more intensely. We can provide prevention if we can. If we can't, we want to be able to at least detect problems very early before any permanent damage is done and treat it, sort of head it off at the pass. We want to improve the ongoing service delivery. We want to improve the care of people living with cancer. We don't want them to have another chronic, complicated, long-term health issues like heart disease. We need to have more dedicated services that provide this multidisciplinary, comprehensive, and holistic care, not only during their cancer treatment, but into long-term survivorship. So with all of this in mind, we've started a Newcastle Cardio-Oncology program. It's quite a wide program where we take our fundamental discoveries in the laboratories right here with the support of HMRI and the University of Newcastle. We look at basic and fundamental models of how do those cancer medications actually cause problems for the heart. What exactly happens? Because if we understand the mechanisms, maybe we can develop personalized cures. We want to develop new blood tests that maybe can identify problems early or predict which people are at risk. We want to develop new imaging tools, once again, to detect problems as early as we can. We want to discover new drugs or repurpose existing drugs that can provide protection against heart damage. And then we want to translate that and take it straight to the patients, but to improve patients' care, to incorporate those discoveries into our everyday patient care, develop new models, multidisciplinary teams, establish, in a sense, one-stop holistic approach to treating both the cancer and the heart disease together. So what have we done for our patients so far? So the program's been around only for 2 and a bit years. We have weekly clinics at the Calvary Mater, which is the cancer center. Coming very soon is a nurse-led multidisciplinary risk stratification clinic, the first in the country. We have patient-reported outcomes study. We collaborate with the Calvary Mater and Hunter New England clinicians to train new researchers and new clinician scientists. We collaborate with many centers internationally to ensure that our patients get the world's best practice here. And we're starting a similar service at the John Hunter Children's Hospital for the children who have or survived cancer. So we're actually quite lucky that with the support of the HMRI, the University, Hunter New England, and our funders, we have the largest and most comprehensive program of cancer in the heart in the country. It started with Doan and myself 2.5 years ago, and we've grown quite a bit. We've got 6 PhD students and a number of other researchers, postdoctoral fellows, research assistants, honor students, pharmacists. So the goal of our program is essentially to both discover fundamental mechanisms, how to translate them into practice, and actually do that clinical practice, apply it to our patients on a daily basis. But particularly, I want to highlight our drug discovery and drug repurposing arm. What we're looking for is, traditionally, we know that cancer medications generally have heart side effects. Heart medications are not as effective usually at cardiac protection as they are when heart damage is done by other means. We're trying to change the paradigm. We're trying to identify anti-cancer therapies which can also protect the heart. And I can show you some of our early work. We're looking at discovering new blood tests that can identify problems as early as we can, earlier than conventional methods. We have a number of fundamental research studies to understand the mechanisms and develop personalized care. So just to show what we've done in 2 years of being here, we've got over 200 patients recruited into our prospective study. This is the largest in Australia prospective study of these patients, where we monitor patients' heart from before cancer treatment and 2 years after the treatment has completed to try and identify the ways of detecting problems early. We've got over 1,000 people that are recruited in specifically looking at the new biomarkers, which is new blood tests to identify the problem. And what does that actually mean? We've identified, in fact, that unfortunately our people who survive cancer are not treated as well as they should for heart disease, and that's really on us. That's something that we've published just last year, and that drew worldwide attention. It's been highlighted in news not only in Australia, in US, UK, and internationally, and has led to a call to action to improve guidelines and management of heart disease in people who survived cancer. This is just a little bit of a plug. It was the second most cited and talked about paper on this topic in the world in 2020. We've contributed to the guidelines internationally about what should be the standard of care in assessing people before they start cancer treatment to reduce their heart risk. And we're specifically focusing on Indigenous Australians, because not only do they have higher cancer risks, their risk for heart disease is worse as well. And so they're particularly vulnerable to problems, and we want to make sure that they receive equitable care. And just a little bit of the exciting data that I want to share. I won't bore you with the graphs, but this data is from last 2 months, and we're looking at a fairly new anti-cancer drugs that we discovered also have heart protecting properties. And you can see it protects the heart by about reducing the damage from conventional cancer treatment by about 20%. And that's actually quite a lot. We have also identified, have some data about some novel blood tests that seem to be in early studies, both in laboratory models and in people, to be early warning markers of developing heart trouble. And that work is continuing. Now, whilst that work is still a little bit away from being in clinical practice, what I want to draw everyone's attention is that please don't ignore your heart, even if you have cancer. And a lot of people that I see in my cardio-oncology clinic think that shortness of breath, feeling really unwell is normal side effect of cancer or cancer treatment. And it might be, but it may also mean that there's a heart problem brewing. So please don't ignore the symptoms: shortness of breath, chest pain or tightness, feeling tired, lethargic. And as Professor Boyle said, any pain really that's in the chest or goes down the arm or up into the neck, please let your doctor know. And a little bit of a plug, if you'd like to participate in our research, if you have a heart condition or if you are interested in being part of our consumer reference group, please contact us. Dr. Trent Williams, who is leading our nurse-led service, would love to talk to you. I'd like to thank our research supporters, but just to finish my talk, I actually want to show this 2-minute movie where some of our colleagues and patients actually have a few messages about the topic.
We've known for a long time that some of the treatments that we use increase the risk of heart damage.
Because we know that if you have complications that result from chemotherapy, your outcomes are much worse.
What we don't want is to have them discontinue cancer treatment to wait for heart investigations, because then, of course, their cancer treatment suffers.
So what cardio-oncology is identifying patients who are at risk of developing those cardiac complications and intervening early and introducing evidence-based strategies to reduce those complications, because we know that prevention is the key here.
I'm stunned knowing what I went home and read about the chemotherapy that I was going to be having, that something like this wasn't a standard kind of thing.
Now that patients are living a very long life after their cancer treatments, the long-term effects of those cancer treatments become more important.
When you get cancer yourself, you're thinking about getting through the treatment, right? But people like your wife, your family, they're thinking about the long term.
We were the first bench-to-bedside cardio-oncology program in the country, meaning that we look at all components of the research, starting from molecular biology, so very basic science and understanding of mechanisms and treatments, all the way through delivering clinical service to the patients and doing clinical research, looking at various best ways of delivering care to the patients, new models of care.
We are changing the mindset of patients who just want to survive cancer to the whole survivorship, so living beyond cancer.
When they know that the long-term damage is not going to be there, and if there is there, they can see it, there's treatment there, there's a plan there, it makes everyone feel a bit calmer.
That would be the biggest peace of mind, saving peace of mind I've had through this.
The techniques that the cardio-oncology team is bringing into it are much more up to date than what we've been using before.
That Newcastle is having national leading healthcare, not only into cardiovascular disease, but as we know, Newcastle really leads the way in chemotherapy and cancer treatment.
The words fail me of how much strength of heart, peace of mind that it provides.
Example of how HMRI research is finding answers and giving hope to people who are suffering from different conditions. And as Aaron pointed out, all of our researchers who are presenting tonight have been supported by, most generously by HMRI donors. So we thank you for your support of this important research. Next, we have Associate Professor Narelle Eather, who is the Deputy Head of School in Education at the University of Newcastle and a research leader for the school-based intervention research for the Priority Research Centre for Physical Activity and Nutrition at the University of Newcastle. Her research focuses on promotion of physical activity and physical fitness among children, adolescents and adults, as well as the development of sport through coach education. Narelle will be sharing with us some important information on how exercise can improve the health of the heart. Thank you.
Thanks, Giovanna. I'm so excited to be here tonight to share some information about physical activity and health with you all. Physical activity and exercise are two terms that you hear all the time. On the TV, posts on social media, tweets, people talk about it, you think about it, not a day goes by that I don't think about it, but that could be just me. But there's so many questions about physical activity and exercise that leaves us wondering, what is it? How much do I really need to do? What type's best for me? Is it really worth the effort? And most importantly, how do I fit it into my busy day? Hopefully in the next 10 minutes, I can answer some of those questions for you. When we talk about physical activity, we're really talking about any body movement that produces that requires energy and uses the skeletal muscles. So anything that you do during the day where you're moving, whether it be at work, to and from where you need to be, and even in your leisure time, anything that you do that's moving is considered physical activity and accounts for your physical activity daily levels. Exercise, on the other hand, is planned or structured activity that has a defined purpose and is repetitive, and usually works towards improving your physical fitness. So what is it about physical activity? We know from strong and consistent evidence that physical activity improves health outcomes, and they go way beyond just the physical benefits of doing physical activity. It's really great for your mind too. Despite having all the knowledge about the benefits of physical activity for your health, physical inactivity is an enduring global health issue. It is now the 4th leading cause of global mortality. In fact, the authors of the 2012 Lancet series described physical inactivity as a pandemic. Physical inactivity not only increases your risk of developing a range of chronic illnesses such as cardiovascular disease, type 2 diabetes, and some cancers, but it also increases your risk of developing cognitive and mental health issues such as anxiety, depression, and even dementia. People who are insufficiently active have 20 to 30% higher risk of death compared to those who do enough physical activity. Up to 5 million deaths per year could be averted if our population did more physical activity. And the story in Australia isn't pretty either. Our children and adolescents, or young people, have been given a scorecard of a D-, with A being the highest, of course, for physical activity levels in that population. Similarly, up to 80% of young adults and 50 to 70% of all adults are insufficiently active and considered either sedentary or low active. And all around the world, the fitness levels of our children are also in decline. It now takes children 15% longer to run a mile than it did their parents. If we look at Australian children, they would finish 200 metres behind a child in 1975 in a 1.6 kilometre run. But what does that all mean? And how much am I supposed to do to keep up those physical activity levels and keep fit? As you can see here, we've got physical activity guidelines across all age groups. And these guidelines change across time. But basically what we're looking at here is the physical activity demands of a child, or the physical activity that a child needs is higher than someone who is older. But we all need to do physical activity to keep fit, healthy, and reap the health benefits. What I would like to pay particular attention to today is 2 important issues. Number one is the intensity of physical activity that is recommended for all people. And secondly, it would be that individuals are encouraged to do muscle strengthening activities now in the phys activity guidelines. Some people out there might be thinking, wow, how do I fit all that into my day? And oh my goodness, that looks too hard. But don't worry, I have a solution to come. Firstly, in addressing the issue of intensity, there's strong and consistent evidence over time that supports a dose-response relationship between physical activity and improved health. That just means the more physical activity that you do, the better it is for your health. But additional health benefits are achieved if you maintain high levels of physical fitness, especially cardiorespiratory fitness or muscular fitness. And how do we do this? To improve your fitness levels, you have to engage in physical activities that are high intensity, make you huff and puff, get your heart rate up, and perform activities that work to strengthen your muscles. The increased amount of energy and the physiological adaptations that you experience through these types of activities put you at lower risk of cardiovascular disease, coronary heart disease, and give you favorable risk factors to disease compared to someone who doesn't engage in those high intensity activities. So based on this latest evidence about exercise intensity, our researchers from the University of Newcastle and the PRC PAN, we suggest that you focus your energy on engaging in activities that are of high intensity. You want to get your heart rate up and make yourself huff and puff where possible. The best part is, if you engage in these types of activities, you don't have to do activity for as long. So here's my solution. High intensity interval training is a type of training that provides a potential solution for addressing physical activity in busy people. The benefits of HIIT in adults, children, and adolescents are now well documented. These include improved fitness levels, improved metabolic health, improved body composition, as well as improved cognitive and mental health. What is HIIT? High intensity interval training is a type of exercise that involves short bursts of high intensity activity followed by periods of rest. The aim of HIIT training is to get that heart rate above 85% of your maximum heart rate. To give you an example, it might look like 30 seconds of high intensity activity, you get your heart rate up, then you have 30 seconds of resting or standing still, and then you do it again. It sounds pretty hard, but it doesn't have to be hard. The benefits of HIIT are that you can complete HIIT training in a short amount of time. It requires minimal space and setup. It's easily adapted for all people, all ages, and all interest levels, and even all skill levels. The best thing is it can also target multiple fitness outcomes at once. For example, we want everyone to improve their cardiorespiratory and muscular fitness, so we can design HIIT programs that cater for both. Some of the work that we've been doing here at the University of Newcastle and through HMRI involves conducting HIIT with different populations. This has been going on for the last 5 years, and we're accumulating lots of evidence to support the benefits of HIIT in a range of populations. The first one, we looked at embedding HIIT into the school day with adolescents in secondary schools, and we investigate the impact on fitness, physical activity, and mental health outcomes. I recently conducted a HIIT intervention in university students on campus, and that was for young adults between 18 and 25. More recently, I've investigated HIIT in the workplace with sedentary office workers. So looking at getting people out of their office chair for 10 minutes a day, get their heart rate up and get their muscles moving. Again, exploring impact on fitness, but also mental health outcomes and workplace productivity. And then an ongoing research project led by Professor David Loomis at the university looks at embedding HIIT in senior secondary school students during their year 11 and 12 studies throughout the school day. And we have had a lot of success through all of these programs. We're building the evidence to show that all of these types of HIIT programs are suitable for use in these settings, that they're effective for improving health outcomes. But how does it all fit together? If we were going to have a look at a HIIT program, it would only be of short duration. So we're not asking people to go to the gym for hours. We're not asking people to take time out of their school day to do lots of exercise. These HIIT programs are really short and snappy. What it would look like in our programs would be a 1 to 2 minute dynamic warm-up, followed by 8 minutes only of HIIT intervals. So 30 seconds on, 30 seconds off, 30 seconds work, 30 seconds rest. Really done well if you work with a partner, one works, one rests, and then you switch over for 8 minutes. And that's it, 10 minutes in total. And really 4 minutes of that is rest. When we think about exercise, and some of the deterrents for exercise is motivation, how do we keep doing this? So what we look at is making sure that we target those things in our program design. So if we want HIIT to work, we've got to get people to keep coming back to do HIIT and be motivated while they're doing HIIT. One of those elements to increase motivation, engagement, and to keep people coming back is the use of variety. So all our HIIT programs have different themes, and our participants get to choose which one they like to do. So we try to cater for everyone's interests. We've got gym HIIT, office HIIT, even a hip hop HIIT, which was popular among the adolescents, some boxing or combat HIIT. And these are the types of things we want people to engage in to keep their interests up, but keep them motivated to keep trying hard during their sessions. We also adhere to the safe principles of delivery to ensure our programs are conducted to a high standard. But one of the really important motivators of our research projects and the impact of HIIT to keep people motivated during those really hard 30-second intervals is the use of heart rate monitoring. And people at home today could do this using their smartwatches. It's easy to keep your heart rate and have a look at it, but it's amazing how much of a motivational tool it is to have your heart rate there, knowing you have to get to 85% of your heart rate to reap the benefits, and having that throughout your workout. But I suppose the key message here about HIIT is that you need to get to that high intensity zone to actually get those additional benefits. We could go for a walk or jog at that lower intensity, but HIIT is all about getting to that high intensity to get those extra additional impact on our muscles and heart health. And how do we do that? We think about 85% of our maximum heart rate. For everyone at home to calculate that, it's really simple. 220 minus your age is your approximate maximal heart rate. So if you determine 85% of that, that's what we're trying to target when we exercise. And we're not saying to keep it at that intensity the whole time. We just have to try and hit that 85% in bursts throughout our day. So whenever you can, to get that huff and puff, to get your heart rate up, you'll have additional health benefits. Not only did our studies show that HIIT can lead to improvements in fitness, muscular fitness, and cardiovascular fitness, as well as mental and cognitive health outcomes, we reported that people actually felt better after they did a HIIT session, which is a bit strange because everyone thinks, oh, that's exhausting. But we measured participants' affective state and how they felt after a HIIT session. And we found that participants actually loved it. They felt better straight after the workout, which was an interesting finding because that is one of the recommendations, that HIIT wouldn't be good for population use because it is too hard. But participants are reporting not only did they feel better after, they enjoyed it, they can see the benefits of participating in HIIT, and they're really satisfied with that short dose, quick bang for buck, 10 minutes of their day, and you could do it up to just 3 times a week to get those benefits. So I suppose with my take-home message today is that HIIT training is a potential solution for getting your heart rate up, getting those additional health benefits beyond just moderate or continuous activity. And it's something that you can do in just 10 minutes anywhere, whether it be in the classroom for school students, whether it be in your office or a space at the office, in your lounge room, or even in your backyard. What you have to do is just take a leap of faith and have a go at HIIT. Everyone can fit 10 minutes into their day. I might finish up there. It might be time for a HIIT workout. Well, thank you very much for listening.
Thanks, Narelle, and thank you to all the speakers tonight. We now have a few minutes left for some questions, and we've had lots of questions come in. So if we don't get to your questions tonight, we will prepare answers for them with the researchers, and we'll make those available to everybody. So we're just waiting for Aaron to join. The first question is, how important is it to get a heart health check with your GP? What's involved with a heart health check? And what age should you start getting a heart health check?
So I think it's very important to get a heart health check with your GP. I think everyone should do it. Everyone once you hit middle age should do it. But if you have any family history, I'd do it at a younger age. Sometimes things like cholesterol metabolism are inherited and they should be treated at a younger age. So if you've got a family history of heart disease, particularly at a young age, I'd start getting the heart health checks earlier, perhaps in your 20s. But everyone, once you hit middle age, should get a heart health check. It involves meeting with your GP, discussing your symptoms, your exercise capacity, your family history, going through those risk factors that I mentioned, the SMURFs, like diabetes, high blood pressure, cholesterol and smoking, and measuring your blood pressure and measuring your cholesterol levels. And once you've done all of those things, you have a much better picture of what your risk is for developing heart disease, and in particular, developing heart attacks in the future.
Thanks, Andrew. My parents are in their 80s. HIIT exercises are probably more appropriate for younger people. What would you recommend for them, or would you recommend HIIT for people in their 80s?
Thank you. That's a good question, and one that comes up a bit. HIIT training can be catered for any age group. We've had studies in young people all the way through older adults. They were with medical conditions and healthy populations. It's just a matter of adapting the exercises to suit. So for one person, a HIIT session might look like periods of sprinting, for example, but for someone else, it might be 30 seconds of walking that gets their heart rate up. So those exercises are easily adapted to suit anyone of any population.
Excellent. Does a plant-based diet benefit heart and artery health?
Plant-based diets generally have been ascribed to have many health benefits. However, just like any other diet, just because it's plant-based doesn't always mean that it is. Doesn't necessarily mean that the diet will be healthy. So there are plant diets that are very healthy. And there are plant-based diets that are not as healthy. And it's really the nutritional composition of the diet, whether it's plant-based, animal-based, or vegetarian, that determines its health, not just that it's plant-based per se.
Excellent. I'm one of 7 males in a family of 8. My father had at least 2 heart attacks and multiple bypass surgery before passing of other medical conditions at 83. When you talk of hereditary incidence of heart conditions, have I dodged a bullet, or am I just on a higher probability curve of future issues, or am I marching towards the inevitable?
That's a great question, and a very difficult one to answer. So the inherited genetic traits that lead to coronary artery disease are complex and not fully understood. There are some single gene defects which lead to very high cholesterol, for example, running in families, but there are other susceptibility genes that we don't quite understand. So what I suggest for people who have a family history like that is to get your cholesterol and blood pressure checked. Those are the 2 things that are easily treatable, that can be inherited and lead to coronary artery disease. And if they're elevated even slightly, start treating them early. There is a lot of data now that lifetime exposure to cholesterol and blood pressure, not just individual readings, is what matters in the end. So if you want to prevent bypass surgery or at least delay it by a few decades, then getting on treatment for blood pressure and cholesterol early is the key.
And one more question. Being a cancer patient on treatment, where do I have to start to have a heart test and when's the best time?
Sure, great question. So just like with any condition, it starts at the beginning. Just because someone has cancer, that could be a trigger to get other health conditions in check, but really it's important to look after your health irrespective of whether you have cancer or not. So basically, like with any chronic disease, the earlier the better. So it's important to get, even more important to get the heart health check if you have other problems, especially cancer, and continue to look after your heart health throughout treatment and beyond.
Thank you. Thank you, Andrew, Narelle, and Aaron, for sharing your research with us tonight. It's an area that we certainly need to invest more into. Apologies for not getting through all the questions, but we will definitely make those available, the answers to those, to everybody. I'd like to just let you know about our next seminar, Sisters, Mothers and Daughters, which is going to be on the 24th of March. So we look forward to you joining us then as well. And I'd like to thank you all for joining us. If anything has spoken to you tonight, or you would like to have more information about any of the things you've heard, please get in touch. An edited version of the seminar will be available to watch online next week. And if you would like to make a donation to HMRI's research, you can do so on our website, or you can at any time give us a call and we'll have a talk to you. Thank you very much.